Okay. Where's Alex? Nice. What I think happened, a lot of people now they're all theirs, but otherwise go because
Okay.
But I will make an announcement down the line.
Thanks.
All about that, okay? Mom, I ended with that.
All right.
And I
I just don't mess up.
About informative phases of data that probably too early to tell. Unless you're
Well, I usually how to do it.
I went in.
You did?
I went in.
Okay.
Okay, awesome. And then I signed the last page. So just come back to me. Other sides as well. I will send back to you this is scanned and copy. Okay, there's the paper forms. About personal health information. This just talks about how insurance your name. Thank you. So happy I was able to make it. Thank you so much.
Give her a minute. Jack wants to hear no jokes.
For Allie.
David Roy. Dr. Roy is the chief of the Pediatric Orthopedic Service at Children's Hospital of New York and the St. Giles Professor of Pediatric Orthopedic Surgery at Columbia University. He has been a member of the faculty at Columbia since 1980. He's continuously been listed in America's Top Doctors by Castle Connolly rankings. Dr. Roy has dedicated his life to improving the lives of children both here and abroad. In 2009, Dr. Roy was the recipient of the American Academy of Orthopedic Surgeons Humanitarian Award, which honors fellows of the Academy who have distinguished themselves by providing outstanding musculoskeletal care both in the United States and abroad, and who help to improve the human condition by alleviating suffering and supporting and contributing to the basic human dignity of those in need. In addition, the Children's Dream Foundation recognized him for his contributions to improving children's health care. Dr. Roy has authored hundreds of articles, written textbooks, served on editorial committees for prestigious medical journals, and has lectured throughout the world. His passion for providing medical services in developing countries has led him to teach and operate in Kenya, Romania, and China. He serves as medical director of the Children China Pediatrics Foundation, a nonprofit organization which provides medical teams to perform surgeries to correct disfiguring birth defects and disabilities of children in China's orphanages. He also founded International Healthcare Leadership, a nonprofit organization which designs and implements educational programs in healthcare management and policy in emerging nations. Personally, I can confirm that Dr. Roy is an excellent surgeon. He performed 2 successful surgeries on my son, and my son is walking better and doing better because of his great care. So I'd like you to give a welcome to Dr. Roy.
Thanks so much. It's a pleasure to be here today. And also, I have to say that it's intimidating because I know that I'm talking to an audience, all of whom know more about this condition than 98% of providers and physicians around. So it's, and I decided to open myself up for some criticism today by giving a talk that basically is the talk I give to providers. And so there's going to be, as I review things, obviously going to be things that you know well, and again, even better than I do. So I'm looking forward to some suggestions and feedback after this is over. Next slide, please. So these are my conflicts, none of which really impact on the talk today, even though they are numerous. Next, please. So I'm going to go through a little overview of congenital myopathies, and then talk again briefly about the genetics and diagnosis of myopathy, and then most of my time I'll spend on the musculoskeletal considerations. Next, please. So and next. So we all know, you can just kind of keep pushing the next slide up here. So we know this is a very heterogeneous group of diseases and still not very common. And they can present from birth right up through infancy and even early childhood. There's the incidence is about 1 in 26,000. And we're going to come back to this in a moment. This is a real problem because when your rare conditions don't get the attention they deserve, and it's always an issue to when we're trying to produce evidence for treatment in rare conditions when they are rare. Among the most common neuronal myopathies, central core and central nuclear myotubular myopathies, and congenital fiber-type dysproportion. Next. Of course, these myopathies are different from another large group of diseases these orthopedic surgeons also see, the congenital metabolic myopathies, where there's deficiencies of energy production as opposed to differences in actual in the muscle fiber itself. Next. The signs and symptoms we're all, again, very familiar with, hypotonia and weakness and hypoactivity of the deep tendon reflexes, delayed motor milestones, and normal intelligence with normal acquisition. The muscle under the microscope, and those broad bodies and it's a new disease. 1963, that was a year from high school. So in my mind, it's a very young disease. And the incidence is 1 in 50,000. This to that issue of how rare it is. And you're going to see me complaining later on about how get good, even natural history data, much less really scientific data on the outcomes of the treatments that we're trying to know. Issues that I emphasize to the providers that I'm teaching and trying to recognize the condition when they see it, particularly in the kids who are late infancy or early childhood. Congenital fractures, cardiac issues can ensue. But when we look at the number of patients that are associated with Number one, it's right up until that the Muscular Dystrophy Consortium at the NIH, and I sent these slides for her to review. She added another couple of genes to the list. So the CK is usually normal. Myograms can show myopathic changes, and the diagnosis, of course, is proven by muscle biopsy. Next. And next. And then next. And here's that laundry list of up till, well, I hope it's correct, up till a week ago. And a tremendous amount going on in this particular area. Next. If you look at the other forms of therapies which are, I think, on the horizon. So the management of the conditions is more managing the symptoms as opposed to actually treating the underlying condition. Physical therapy, nutritional support, assisted ventilation, and genetic counseling. The symptoms, including orthopedic issues, we will be talking about as we go through the talk. So the follow-up care is, of course, really vital. We want that, from the orthopedic perspective, infants they should be seen 2 or 3 times a year. Older children, once or twice a year. We definitely need. I like working with a combination of pediatric physiatry, and orthotist, and orthopedic surgery is kind of a minimum moving forward. I'm lucky enough in my environment to also, of course, have close affiliations with our pulmonary team, and when needed, the team to support kids in surgery. So this is the problem again. Given the low incidence of the disease, there's really insufficient evidence to really guide treatment, and there's a lot of variability in care. So when you as providers, as caregivers, are going to see your orthopedic surgeon about a specific problem, the likelihood of you getting the same answer when you go to me, when you go to Boston Children's, or when you go to Children's Hospital of Philadelphia, or when you go to Los Angeles Children's or Denver Children's, is about 0, right? Because that, even though there are a relatively small group of people that are expert in care on myopathies, there's not necessarily a consensus around treatment. And as we go through spine, hip, knee, and foot, I'll point these inconsistencies out. I don't have a really smart overall answer for you, in terms of who to listen to. But I think that it's kind of making a broad excuse for the profession. That the reason for that variability is that there's not evidence to support any one given treatment modality. So what are the indications of surgery? What are the goals? What is the prognosis? And what kinds of surgeries are possible or that maybe should be considered given what we know? So some of those indications would include progression of deformities of a limb or of the spine, threatened skin that implying skin threatened by deformity. Are we going to do something which is going to extend life or prevent medical complications? Are we going to increase function by doing a surgical procedure? Then the assessment of the patient's general health is also a really vital part of this whole determining indications. If a child is too ill, doesn't have enough nutrition or pulmonary support, then perhaps the surgical procedure should not be. And then, of course, are there alternatives to surgery? And do we totally understand the risks of not operating? And this would imply that we understand the natural history of the problems that we're treating. And the fact is we don't really have a good grasp on natural history. Because believe me, the natural history is a moving target that has changed. You can imagine the difference in the prognosis for a kid born with a significant involvement of congenital muscular dystrophy in 1980, when I went into practice, and in 2016, and it's night and day. It's totally changed. So when I look at what we've been doing at CHONI over the last 25 years, it's not really very useful, right? Because those kids really didn't get the same kind of care that your children are getting now. Next. So what's the measure of outcomes? This is another important thing, even though if we have an opportunity to follow our patients when we treated them. Are we going to be talking about functional level, ease of care, presence of pain, complications, using written or computer-based quality of life assessments? I'll tell you what we're not looking at to determine outcomes, or at least what in my mind should not be used, would be just looking at x-rays and range of motion. That's really not what measures the outcome. What measures the outcome is the kid functioning better? Does the kid have less pain? Is the kid's overall prognosis improved by the intervention? So again, delaying progress of the disease, and this is a rather some hubris in that statement. What I'm talking about really is delaying progress of a specific affected disease, like a hip dislocation, or scoliosis, or that. And one of the models that I pointed to, which is the Toronto muscular dystrophy model, which came about for a sad reason in Ontario 40 years ago, starting about 40 years ago, 45 years ago. Boys with Duchenne's were brought together to live together in group home in Toronto. So there were tens of kids there who grew up together, and it provided a kind of medical experiment looking at the variability of the kids' outcomes based on the treatments that they got. And it was very clear early on that the boys who got scoliosis surgery, when the curves were small, in the 30 to 40 degree range, had a much better outcome than the boys who did not get that surgery. And so that this was a way of, so when I'm talking about this disease model, it is possible, if it's organized and correctly applied, to improve outcomes, long-term outcomes with surgical interventions. And even though this work, of course, this model no longer exists in Canada, kids with muscular dystrophy are at home the way they are here in the States. But it's still that work is very important, even seminal in helping us to design our work around scoliosis treatment. So the care guidelines that I talk about with I'm talking to physical therapists and to my residents and other graduate students and our fellows, is promotion of physical activity and avoidance of inactivity, prevention and correction of deformities as they develop, maintenance of bone health, general bone health is very important, management of pain, education and dissemination of the information on therapy. Really, really important. So what we do know, we certainly should be disseminating. Provision of assistive technology to maximize function, and access to the appropriate specialized orthopedic management when it's necessary. And we want to direct patients toward our research studies so that we can learn more about the conditions and about the outcomes of the treatments that we're using. Next. So the consistent follow-up care is really important as well. And I want to put a plug in here for continuing follow-up care after maturity. So there isn't some magical time after age 18, 19, or 21 that an individual with a congenital myopathy doesn't need care anymore. And so that's one of the gaping hole, if you will, in our long-term follow-up data is that once patients leave the children's hospital, kind of environment, the pediatric providers, there's the data just disappears, and the patients just I say, which is not maybe not a nice analogy, they fall off a cliff. They go away. They're not getting care. And exercise and activity modification, of course, is important in our myopathy patients, and we emphasize that as well. Next. So orthopedic treatment and respiratory involvement are critical. Cliff asked me a question earlier today, said, how do I prevent scoliosis? And unfortunately, we don't really have a way of preventing, although it seems to me pretty clear from looking at the data over the last decade that positive pressure ventilation has had a real impact on the development of the chest wall and on the, and I think the improvement in the prognosis for scoliosis. That seems to delay the onset of scoliosis. And there's some pretty good evidence, not necessarily in pneumothoracic myopathy, but at least across the common myopathies that positive pressure ventilation absolutely helps prevent the chest wall deformity and therefore respiratory impairment and therefore spine deformity. So the scoliosis is more common in kids with axial weakness, as I say, weakness of the trunk. And it kind of makes sense. If you don't have the muscles to hold up the spine, scoliosis is going to be more likely to be progressive. Next. So actually, I already mentioned this. I'll mention it again and again. Your child is going to have anyone who is operating on your kid, even if it's